Good morning, good afternoon, and good evening, everyone, and welcome to this webinar titled An Introduction to Infectious Disease Modeling. This webinar has been sponsored by ICON, so big thanks to them for helping to make this event possible. We're very fortunate to have three speakers joining us today. First up, we have Dr. Maria Zivkovic-Gojovic, Senior Consultant in the Global HEOR and Epidemiology team at ICON. Maria is experienced in using various types of dynamic modeling algorithms with expertise in agent-based modeling. We also have Dr. Richard Pittman, who is the lead health economist and epidemiologist in global HEOR and epidemiology at ICON. He has over 30 years experience in the epidemiology, burden of illness, and mathematical modeling of infectious diseases, particularly relating to the cost-effectiveness of interventions and policy issues. And lastly, I'm happy to introduce Pragya Khurana, an epidemiologist also in global HEOR and epidemiology at ICON. Pragya has focused on epidemiology and data analytics projects within the real-world evidence space with experience in multiple therapeutic areas, including oncology and infectious diseases. And with that, I'd like to welcome our first speaker, Maria. Thank you so much for being here today. Please take it away whenever you're ready.
Thank you, Sydney. This webinar is on infectious disease modeling, and first I will start with agenda for today's talk. So the agenda for today's talk consists of a few topics. First, we will talk a little bit about the introduction to infectious diseases. Then we will touch up on modeling in general, and specifically infectious disease modeling that use dynamic transition models mostly. Then we will present a specific case study of infectious disease modeling using an influenza as an example. And in the end, we are going to give a final remarks with the list of potential applications of infectious disease modeling in pharmaceutical industry. So let's start with infectious diseases. What are infectious diseases and why in general they are so important? Infectious diseases are diseases caused by microorganisms such as viruses, bacteria, fungi, or parasites. They are very infectious and they can spread from one person to another through close contact mainly. Those contacts can be either contacts with bodily fluids, aerosol contacts that spreads through coughing or sneezing, or they can also be contacts that are spread via a vector, like for example, mosquito. They are also leading cause of morbidity and mortality worldwide, especially in low and middle income countries. Beside that, they are significant economic and social burden. They are often associated with high healthcare costs and with significant life and productivity disruptions. However, we know that majority of infectious diseases are preventable, and also that preventable services for infectious diseases are often very, very cost effective. So knowing all that, what can we do about it? Can we do something about it? And here I have a list of questions that are commonly asked when it comes to controlling and preventing the spread of infectious diseases. So some of them are, for example, what can we do to reduce the number of infectious cases in the community? What measures needs to be applied, and how can we choose the most appropriate measure to apply? Can we reduce them enough so that infection is completely eliminated? And specifically, can we estimate the timing of each intervention? And in the end, can we maintain the intervention at a level to permanently prevent the future infection of the disease? So before we actually give answers to these questions, I would like to introduce you with the concept of basic reproductive number and effective reproductive number. I'm sure that most of you know what that, but let's reiterate. Basic reproductive number is the number of new infections caused by a single infected individual in a totally disease-naive population. That means that at the point when the basic reproductive number is measured, we have no knowledge of the disease and we have no measure that are introduced. It represents the disease itself. Therefore, if it represents disease maximum ability to spread. It is fixed value as it is disease related. It is always greater than 1, and it can go up to 18, for example, for measles. So one infected individual can, in case of measles, infect 18 new individuals during its lifetime of being infectious. It is also equal to the effective reproductive number, but only at the beginning of the epidemic. So what is effective reproductive number? Effective reproductive number is also the number of new infectious cases caused by a single infected individuals, but it can be measured at any specific time during the epidemic. It represents the ability of disease to spread given some circumstances, for example, the knowledge of the disease or the measure that are being introduced at a certain time. Its value can be below 1, and in that case, we will have falling prevalence. And as we said, it can be measured at any time of the pandemic. So let me show you how that looks. Here we have a representation of a typical epidemic curve in relationship to the effective reproductive number. So at the beginning of the epidemic, we said that R naught is equal basically to the effective reproductive number. And in this case here, we set that to be equal to 2. What that means? That means that one infected individual is going to produce 2 new infected cases. Therefore, this will result in epidemic to surge and the appearance of new cases. If for some reason effective reproductive number uh, decline, let's say that at this point we are aware that the epidemic is there, we reduce our contact, or there is a certain measure that is introduced, we can see how the number of infected cases starts to slow down. And if it continues to drop to the level where R naught becomes equal to 1, which means that only one infected individual is causing one new case, we can see that curve actually flattens. If it continues to decline even more, then we expect the infection to decline as well, and so on. If it goes to 1, it will flatten again, and if it continues to increase, we will see the increasing number of infected cases, and so on. So what are actually the factors that can influence this variation in effective reproductive number? Broadly, we can divide them into 2 categories. One category are the factors that contribute to the generation of the immunity in the population. And those factors can reduce the effective reproductive number and therefore control the epidemic. On the other hand, factors that increase the RT and increase the epidemic are factors that normally lead to the replenishment of new susceptible individuals. So in this case, for example, we can have the loss of immunity in terms of like waning immunity of the vaccine, or maybe antigenic shift or drift, or the inflow of new births or new migrations, the inflow of new susceptible population. Factors that decline RT can be, for example, virus-related factors like R naught, viral generation time, mitigation strategies like vaccination and its characteristics, like, for example, coverage, frequency, or behavior of the population and towards the vaccination. So what is the takeout from here? If we are able to develop the measures that can control those factors, and by controlling, reducing the number of infected cases and controlling the epidemic, we would be able to control the disease spread. And the question is, how can we do that? And for that, I'm going to pass to Richard for further explanation. Thank you.
Okay, well, thank you. So Maria has outlined some of the key interactions driving the transmission dynamics of infectious diseases. So how can we capture these interactions within a model? And indeed, what do we mean by a model? So when it comes to infectious disease modeling and modeling more widely, in fact, a model is essentially a mathematical representation of the real world, of a real world problem or circumstance, a caricature, if you like, of reality that captures the sort of those essential characteristics that are relevant to the particular problem that you're investigating. Now that our appreciation, our understanding of that problem is usually gleaned from information within data. So within real world data that is collected and provides insight into what we're trying to investigate. And it is against that sort of data that models are calibrated. So in fact, they're designed, if you like, to fit our understanding of a particular circumstance as represented within data that we can measure. That process is usually iterative in that the goodness of fit, the adequacy of the model usually has to go through some sort of refinement process in order to ensure that it captures those essential characteristics, those essential drivers. But once that has been achieved, you then have a tool, and quite a powerful tool, that can be used to look at various scenarios. So if circumstances change, such as the introduction of an intervention like a vaccine, for instance, you can look at how that is then how the model would predict the consequences of that change. And you can use this tool to look at sort of real world solutions, and it helps us to understand and gain insight into how we can solve the problem that we set out with. Okay, so sort of more broader questions in terms of why do we take this approach? So mathematical models provide a framework for understanding and discussion in which that is very, very clearly set out with explicit assumptions. It allows us to take account of uncertainty in a way that is transparent, and it can provide insight into solutions to problems, or it can inform the choice between alternative decisions where in very sort of complex scenarios. It can also give answers to complex questions that we couldn't otherwise analyze without the use of mathematics. And there are means of evaluating the sort of efficiency, effectiveness, value, and impact of any health-related service through health economics. So the two, it's a very powerful tool. So when it comes to infectious disease modeling, models really can be classified into one of two types. They are either static or dynamic models. The difference being that within a dynamic model, the rate at which susceptible individuals become infectious, or infected rather, depends on the number of infectious individuals in the population at any one time. So there is this sort of feedback loop. So the number of infectious individuals at one time directly influences how many infected individuals there are later on. As such, these systems are inherently what's called non-linear. So there is this sort of feedback system. Static models, on the other hand, treat that risk of becoming infected generally as a static fixed parameter, or if it varies, then in a way that's not directly linked to the model itself. Yes, so dynamic models, they themselves can be either sort of probabilistic, stochastic type models, or also deterministic models, which are sort of systems of differential equations, for instance, which both can be population based, these sort of statistical stochastic models can be also used to in model sort of individual-based models. So where you actually model the infection of a sort of defined individuals. Okay, so why or when essentially would you use a static model as opposed to a dynamic model? So static models are generally thought to be acceptable if you're looking at a circumstance where an intervention has no impact on disease transmission. So that might be because an age group that has this disease don't play a role in the onward transmission of disease, for instance. In those circumstances, then a static model might be thought to be acceptable. They are also sometimes used as an initial approximation where a projection is thought, analysis suggests that an intervention is cost effective and that including the dynamics within the model would simply enhance the cost effectiveness via prevention of secondary cases, for instance. That approach, however, is very risky. It is, without actually doing the modeling, it is not always intuitively obvious how including dynamics in the transmission model will impact the cost effectiveness analysis, for instance. And it does not always enhance cost effectiveness. If the sort of non-linear effects, the indirect effects that arise from the dynamics of an infectious disease can have many side effects, if you like. So, for instance, reductions in the probability of being infected, leading to changes in the mean age of first infection, for instance, and the consequences of that would be dependent on the relationship between age and morbidity and mortality. Ignoring dynamic effects also essentially leads to an incorrect valuation of an intervention, and in sort of policy making, that can lead to very poor public health decision making if policymakers use those estimates to decide, for instance, on the optimal allocation of a limited healthcare budget. So we would generally say that dynamic models should always be used when an intervention has an impact on transmission. For instance, through mass vaccination, increasing the proportion or decreasing rather the proportion of susceptible individuals, or non-pharmaceutical interventions such as school closures or national lockdowns, for instance, fundamentally changing the contact rates between individuals, where antivirals, for instance, might impact the duration of infectiousness within a significant number of infected individuals, or indeed the use of such things as antiretrovirals may affect the probability of transmission per act of contact. And so the ability to capture changes in the risk of infection allows these sort of dynamic models to account for the inherently non-linear dynamics of infectious diseases. And as I say, predict changes in things like the mean age of first infection, and resulting impact on morbidity or mortality, and allows us to also do things like model the competitive advantage between different pathogen strains, so providing insight into strain replacement following vaccination or antimicrobial resistance. Dynamic models should also be used in any circumstances where decision makers are interested in either the local elimination of an infectious disease or elimination at a global scale, if you like, so eradication. And that's particularly important, for instance, with vaccination programs, because the indirect effects that that arise from infectious disease dynamics mean that you don't have to treat everybody in order to achieve those as a local elimination or eradication, and you require a dynamic model in order to understand and to take account of those sorts of interactions. And finally, if reinfection of treated individuals depends on the prevalence of infection in the population, as in many sexually transmitted diseases, then um, dynamic models are definitely required. Okay, I'm going to touch briefly on some considerations around uncertainty in these types of models as well. So, as is common with many decision models, particularly in sort of health economics, there are various levels of uncertainty that may need to be accounted for, either within the parameters themselves, so how well we measure them, the sorts of biases involved, within the structure of the model itself. So we've talked about static versus dynamic, but also um, it can also arise out of uncertainty in the evidence. So if the the real world circumstance that we're trying to create a caricature of in the model, as it were, isn't very clear, then the picture we're caricaturing is blurred. So there is uncertainty of that type. And then there are sort of methodological uncertainties as well. So around things like the choice of discount rates, how long you run the model for to make predictions, that sort of thing, the sort of time horizon. But when it comes to infectious disease dynamic models, I just want to highlight one particular area. So, as is common with much sort of economic, especially health economic modeling, parameter uncertainty is very often accounted for within a sort of probabilistic sensitivity analysis, where we look at the uncertainty around the estimates of individual parameters and repeatedly sample from those sort of joint distributions, so from each of those distributions, to produce lots and lots of runs that allow us to see variation in our outcome parameter. So that's fairly standard. So, but the non-linear nature of infectious disease models and of infectious disease epidemiology, not just in the modeling but in reality as well, mean that the outcome variables are very sensitive to changes, to the uncertainty within the inputs, the variables in our model. And what that means is that paradoxically, if we're calibrating against data from some period in the past, you can get very accurate estimates of the inputs because, as I say, the small changes in inputs produce big changes in the outcome. So if you're fixing to a particular outcome, that gives you feeds back to give quite very accurate estimates of your variables. But once you come so that's the upside. The downside is that when you come to making forecasts, if you like, so looking into the future, small changes in those calibrated parameters can produce big changes in your forecasted epidemiology and outcomes. Okay, so what I'd like now to do is to really just go through a case study that sort of highlights some of these aspects. So the study we're looking at is some work we did to look at the cost effectiveness of childhood influenza vaccination in the UK. So we set out to create a flu model for flu in kids, an economic model with a dynamic transmission component that captured the indirect effects. And to use that model to examine the cost effectiveness of what was then an investigational influenza vaccine, so a live attenuated influenza vaccine in children in the United Kingdom. and to compare that to comparator vaccines alternatives. So this leads us to the sort of the basic structure. So the top half of this slide is essentially the mathematical model that we had, and which took, and the lower half, it sort of refers to the real world data that was used to inform this. So we built a model. It was a deterministic compartmental transmission model. So you effectively subdivide the population into a set of classes. So into individuals who are susceptible to infection, so they don't have immunity, who may become infected and transitioned into the sort of an exposed class. So these are people who are infected but as yet to develop infectious disease. So they're infected but not yet infectious. So the red classes in the sort of the red box are infectious cases. So people who then develop disease and become infectious, and those infections may either be asymptomatic or symptomatic. That's why there are two boxes there. And a proportion may die, or unfortunately, or may go on to recover with naturally acquired immunity, so that the recovered class there are immune to infection. Immunity might also be gained by vaccination, so you could move straight to an immune class, so without the infection part. So that's the whole idea of vaccination. And the vaccine or naturally acquired immunity might can wane over time, returning individuals back to the sort of susceptible class, where they can then be reinfected at a later stage. So the data that was used to inform this was essentially the temporal dynamics of influenza by age in different settings. So within primary care, within sort of GP sort of primary care settings, within hospital, so hospitalizations, and also in terms of mortality. So that sort of brings us, first of all, to the data side of this. So that data was derived from a set of UK databases. So there is so influenza-like illness attributable to in GP visits that can be obtained from what's now the clinical practice research data link, so CPRD database. There is information on ILI disease within hospitalizations. So there's the hospital episode statistics, and the Office for National Statistics provides mortality data, which again you can extract influenza-like illness from those death records. Now the problem is, of course, that ILI is a broader definition than just flu, and there are other diseases that play into ILI. For instance, RSV, the sort of rhinovirus, cold-like viruses, and even sort of some bacterial, so strep pneumonia can also present a sort of a flu-like illness. And so we had to tease out the flu component, and that was done using a sort of multiple regression approach, where we used the temporal dynamics in laboratory confirmed cases of a panel of pathogens, all of which could cause ILI, including flu, RSV, all the ones that I mentioned. So we use the temporal dynamics in those laboratory confirmed cases to attribute the proportion of the observed ILI to each of these contributing pathogens. And in so doing, we're able to estimate the proportion of these cases over time that was attributable to flu. So providing us with a temporal pattern of flu, be it admissions or GP consultations or mortality over time. Those outcomes we could attach costs and life year decrements to, and so giving us a sort of quality and cost based measure of health. We then looked at so having calibrated our model against that data, we were then in a position to use it as a tool to look at various vaccination scenarios. And the ones that we looked at were various levels of coverage, of vaccination coverage in 2 to 18-year-olds. And a further scenario of 80% coverage in 2 to 4-year-olds, either with the target live attenuated influenza vaccine or a comparator vaccine. And these scenarios were in addition to the existing background vaccination for flu, which was a policy essentially of vaccinating the elderly and at-risk groups. Okay, so that model took into account things like what's called the who acquires infection from whom matrix, so it's a WAIF matrix. So that's essentially captures the age-dependent contacts between individuals. So how individuals at different ages just mix with each other, basically, in a community. We took account of the transmission coefficient of flu, so how likely flu was to transmit if an infectious individual came into contact with a susceptible individual. We took into account the sort of clinical details of disease, of infection, so the time it takes from infection to becoming infectious, so the latency, how infectious, the duration of infectiousness, and once you'd recovered, the duration of immunity and how that waned over time. And all of those things can be summarized, as Maria pointed out, within a basic reproductive number, which for this was about 1.8. As this was a sort of this was a cost effective, an economic analysis as well, so they were the costs and benefits were sort of discounted at a sort of annual 3.5% rate, which is fairly standard for the UK, over a 15-year time horizon. And the sort of impact of vaccination is illustrated here. So you can see, if you look along the bottom, there are the different scenarios that I outlined. So the increasing coverage in from 10 up to 80% in 2 to 18-year-olds, and then the 80% coverage in 2 to 4-year-olds. And we show the number stratified by age of averted infectious cases of influenza and the flu comes in two types, the flu A and flu B, so that's split out. And what is particularly interesting in this is that you will see, particularly as and it becomes more obvious as coverage increases, that there are a significant number of cases averted in age groups that are not targeted for vaccination, so age groups other than the 2 to 18-year-olds. And it thereby very clearly demonstrates the importance of capturing the impact, the dynamic impact of sort of the prevention of secondary cases and the sort of that a dynamic model will provide, and that a static model will miss. You can represent these results on a cost effectiveness plane. So if we look at the numbers of QALYs lost and their associated cost. So these are the outputs of the sort of probabilistic analysis that I talked about. So where we sample the uncertainty in all of those input parameters and look at how that affects the estimate of QALYs and lost and cost. And you can see the big sort of shotgun region on the left, a sort of blue cloud, is a scenario in which we simulated no vaccination at all. So if we removed all vaccination, the sort of brown cloud is what was then the current policy. So that was vaccinating the elderly and at risk. And then you can see sort of clouds for each of the increasing vaccine coverage within 2 to 18-year-olds. And what you will see, I mean, you wouldn't expect these clouds to go into the positive the side, so to go up to the positive x-axis, as it were, because unless vaccines can actually improve your health without separately from preventing flu, you're not going to end up with a net gain in QALYs, but you're preventing QALYs being lost due to flu. So there's a boundary, if you like, at on the right hand side. But as coverage goes up, of course, you would expect the numbers of cases of flu prevented to increase, so you lose fewer QALYs. But you can see that there is a degree of diminishing return in that after a while your costs start to escalate quite quickly as that line sort of, if you follow the clouds, it starts to go up. And so there are diminishing returns, and the clouds themselves become smaller. That's because as you get very high levels of coverage, you may start to reduce transmission, and so the impact of variation is reduced. If you look on a cost effectiveness plane with incremental QALYs, so the previous one was absolute, so this is incremental relative to what was then the current policy. That was, as I said, vaccinating the over 65s and at-risk groups. And if looked over a 15-year sort of cumulative time frame, you can see the blue, the green, and the purple clouds are the 2 to 18-year-old scenarios with increasing coverage. But we've also included on here in the top left a sort of a purple cloud, which is the cost effectiveness, so the cost per QALY estimates from a static model, so an equivalent static model, and it clearly shows the impact of including indirect protection in this analysis. So the enhancement of the QALYs that are prevented from being lost, and the reductions in cost. We also can look at to take this analysis and taking account of all of the variation that is in there, so the spread of all of these estimates of cost per QALY in each scenario, and look at the probability of each scenario being cost effective at a particular cost effectiveness threshold. And by distilling all of that uncertainty and the estimates of outcome and cost, it allows us to then look to see for any particular cost effectiveness threshold which scenario has the highest probability of being cost effective. And therefore, at any particular threshold, cost effectiveness threshold, we have an indication of what is likely to be the best, the policy that's most likely to be cost effective. So it's a very powerful tool of taking account of a considerable amount of uncertainty, our understanding of disease transmission dynamics, of the costs involved, and making a informed decision between different vaccination policies. And so, as I say, in conclusion, this methodology allows us to account for indirect effects and the significant impact they have on estimates of cost effectiveness of a vaccine in a way that static models cannot do. and demonstrates how sort of dynamic transmission modeling allows us to estimate and indeed compare multiple scenarios, the cost effectiveness of individual scenarios, and compare across multiple scenarios, whilst taking into account all of the uncertainty involved. Okay, so thank you, and I would like now to hand over to Pragya, who will provide some final sort of thoughts on things.
Thank you. So I'll be highlighting some key points and share how we're moving forward. So as Maria and Richard have shown, dynamic modeling, transmission modeling is highly advantageous, and this is a powerful approach that provides quantitative insights to help answer complex infectious disease questions, as was highlighted in the influenza case study. So these models provide a sophisticated framework that's able to capture mechanisms that other models are not able to. So with communicable disease interventions, such as vaccinations, there are population level effects. And using dynamic modeling approach, you're able to incorporate indirect effects. They can also capture smaller details and be used to identify critical drivers that may be undervaluing the intervention if only using a static modeling approach. And quite importantly, uncertainty in parameter values can be more influential in dynamic than in static models because of the nonlinear feedback effects that were talked about earlier. So all of these different components of dynamic modeling can be captured and be used to inform cost-effective analysis and the wider value of interventions that target infectious diseases. So these are some examples of applications which span across epidemiologic studies of estimating change in burden of infection due to an intervention, or evaluating and comparing different intervention strategies. As we saw with the case study, we can also evaluate cost effectiveness and budget impact of vaccination programs. And with that, more widely, vaccine policy analysis as well. And dynamic modeling is also advantageous because it incorporates the real world nuances of transmission. And with what we've experienced in the past few years in particular, that's highlighted the need for quantitative and evidence-based decision-making within public health. And applications of mathematical modeling can be used to inform that evidence generation and determine what additional data is needed. So with ICON has performed extensive research within infectious diseases and vaccine development. So here's some additional resources on this slide. The titles of the articles are links, are hyperlinks, so you'll actually be able to click on them and be able to explore some additional resources. And also, you're able to click on these icons as well to check out the ICON webpage and social media links to get updates on the latest industry and company news. So I'll now shift over to Sydney for the next section.
Thank you, Pragya. I think we're ready to jump into our Q&A, so I'll invite the other speakers back on to join me. So let's jump into our first question here. Appreciate all of your presentations this morning. That was excellent. For what diseases other than influenza is it particularly important to consider dynamic models instead of static models, and why?
I will take that question, Richard, if that's okay with everybody. So,
yes, sure. Go for it.
Okay. So what diseases? Generally, I would say that for every disease, when there is an intervention that can have a direct impact to the disease spread and transmission routes, I think that we should consider introducing dynamic models. The reason for that is that dynamic models are very complex in design, and therefore they are able to capture all small details in disease transmission dynamics, particularly something that you pointed out, the nonlinearity. And therefore, they will be able to better capture the effect of any applied measure, generally to capture all the consequences of applied measures. So when we ask what diseases specifically, so I would say all diseases that has an interaction in terms of close contact transmission, definitely all airborne transmitted diseases. Um, Specifically, yeah, I would like to mention also sexually transmitted diseases, also because of the contact dynamic and specificity of those contacts that needs to be described in rather in details. Yeah.
Response. Thank you. I don't know if Richard or Pragya, if you have any additional add-ons to that.
That sounds pretty comprehensive to me.
Excellent. Okay, we'll move on to our next question then. And I just do want to remind the audience to please continue to submit those. We'll be addressing as many as we can. Okay, Cynthia asked, which software have you found to be most useful for infectious disease modeling?
Okay, so the dynamic transmission models are, depending on their complexity, I mean, we would normally build them in something like C++, but more simple models can be included. You can use software. I mean, there's Berkeley Madonna is available, but that's not those sorts of software packages are good to explore the disease transmission components of relatively simple systems. But when it comes to their use with cost effectiveness analysis, for instance, with economic analysis, then that becomes a bit more problematic. So it's usually a high level programming language. Some people use R as an interface, but again, that is in reality the packages that do the sort of integration for you are also written in C. So there is C under the bonnet as well, but that their sort of DSolve and things within packages within are useful tools. But as I say, we would normally code in C++ or some similar high level language, and the cost effectiveness is very often done in a spreadsheet.
Perfect. Great response. Very detailed. All right, let's jump to the next question. When might the inclusion of disease dynamics reduce estimates of cost effectiveness?
Okay, well, in the bit that I talked about, we covered that a little bit. So when an intervention, so for instance, an example of that might be when the introduction of a vaccine reduces the probability of becoming infected. As a consequence of that, there is a lower probability of being infected, and therefore individuals take longer to become infected. And as a result, the mean age of first infection goes up. And if there is a particularly strong relationship between age and morbidity, that can have negative consequences. So, for instance, the classical example of that is rubella. So, in pre-vaccination, people would get rubella at a relatively early age, a fairly mild, relatively benign infection. But the introduction of vaccination can increase the age of infection. And if it does so to the point where infections start occurring in childbearing years, then the consequences of getting rubella whilst pregnant, congenital rubella syndrome, are extremely serious. And in those circumstances, introduction of a vaccine, if coverage is insufficiently high, can lead to negative consequences, and therefore that feeds through to the cost effectiveness analysis. So those types of scenarios are where that sort of negative effect can happen.
Okay, fantastic. Thank you. Okay, our next question is a good one. Raj asked, can you please extrapolate in a few steps the learning curve from basic to advanced level of disease modeling?
Okay. Maria, do you want to take that? Do you want me to take
that? You can take it, yeah. It's okay.
Okay, so learning curve from basic to advanced levels of disease modeling. Well, I guess the first part of this of infectious disease modeling is an understanding of the process of just the mathematical process of modeling a dynamic system. So understanding the way in which an individual, a population can be, it's probably best to start with something like a compartmental deterministic model. So the way a population can be subdivided and into the classes that I talked about earlier, and represented in a set of differential equations. And then how those differential equations can be solved numerically within a system. And that's relatively straightforward to do. Doing it accurately and across many variables gets a little bit more complicated, but so it's building up an understanding of the basic processes of doing that, alongside appreciation of the epidemiology, I suppose, of infectious diseases. So you have to build both of those arms. Once you've done that, I think then the more you start to get a feel for the dynamics of an infectious disease and how those change with changing levels of susceptibles in the population, how sort of vaccination can slowly replace natural immunity in a population, and why you can control diseases without having to vaccinate everybody. So building up an intuitive understanding of that, and then the more advanced, I suppose, going on from that is when you start to look more into the calibration and parameterization of these models and evidence synthesis required to go into them. So some of the Bayesian techniques, for instance, for interpreting surveillance data and that sort of approach. So how do you tease out the sorts of dynamics that you've been seeing up to that point in a more theoretical framework? How do you see those dynamics? How do you measure them in the real world underneath all the layers of uncertainty that come from our surveillance systems, our data collection, and how you pull all of that together to then end up with a final model.
Perfect. I hope that helped. That was a very comprehensive response. Thank you. Okay, moving on to the next one. How do non-pharmaceutical interventions impact disease dynamics?
I can take that one. Basically, the main goal of any intervention, including non-pharmaceutical interventions, is to reduce the number of transmissible contact in the society. So when we say non-pharmaceutical measures, we know that normally we mean school closures, wearing masks, or maybe contact tracing, for example, that we had through that will lead to some kind of isolation and quarantine. But in terms of reducing the contact using the measure, I think that the main difference between non-pharmaceutical and other measure is that non-pharmaceutical measures are not permanent. I think that the impact of non-pharmaceutical measure can be observed as more in terms of slowing the epidemic rather than actually controlling it, and introducing them maybe at the beginning of the disease, at the beginning of the epidemic, to maybe slow it down, delay until the other measures, like for example, vaccination, can take part and establish sort of like a permanent contact transmission, like through immunity.
Okay, great response. I think we have time for one last question. So I'm going to ask this next one here. Pediatric vaccination has now been implemented in the UK. How does the reality of this compare to your predictions?
Okay, I can take that one. So yes, indeed, pediatric vaccination has been introduced into the UK. It has been phased in over a number of years, starting off with a reduced age group, so with younger kids to start with, in an initial set of pilot areas. That has now been expanded out nationally, and there is now debate about expanding it to sort of to 17-year-olds, but that is not hasn't been implemented yet. And so the I suppose the reality is that the progressive nature of the implementation means that a direct comparison with the modeling that we've done has not been possible. However, within the age groups that they have targeted, certainly the results are consistent with those that were produced through the modeling. So consistent, but it's challenging to do a direct comparison because the circumstances are different.
Yeah, that makes
If
sense.
we come back in 10 years' time, we might be able to have a better answer when one more wider use has been implemented.
Absolutely. Fantastic. Okay. I suppose we can actually just kind of have one last add-on. This question is a little bit similar to what you just explained, but let's see if there's any add-ons that you can provide for that. How well do projections from dynamic transition models predict real-life cases? So are they better at predicting some diseases than others?
Who do you want to? Maria, do you want to take that, or do you want me to do
it? You can take it out because you already talked about it, so it would be better as a continuation.
Okay. Okay. So predict real life cases. So as I sort of hinted in the talk, predicting. So making, it depends what you mean by prediction. So forecasting what's going to happen next year is actually rather difficult with infectious diseases. Certain diseases that are that tend not to fluctuate so much, so that are not subject to seasonal fluctuation, particularly, for instance, and in which or against which there is sort of long-lasting immunity. So the childhood infectious diseases, for instance, the infectious disease models in those cases where we know a lot about the epidemiology and we understand the uncertainties quite well. They are reasonably good. For more erratic diseases, such as flu, for instance, which is seasonal, which has sort of antigenic drifts, so there are the changing strains over time. Long-term forecasts, what I would call, are difficult to make. However, bear in mind that that uncertainty also applies to any decision making associated with those diseases. So it's not just a problem with dynamic modeling, but it's a problem faced by any policymaker that has to make a decision about flu, for instance. And our ability, so these models' ability to be incorporated into analyses that take account of that uncertainty. And I would make a distinction between the sort of forecasting, so trying to tell you exactly what flu is going to do next year. I draw a distinction between that and what I would refer to as predicting the impact, the relative impact of an intervention. So I might not be able to tell you exactly what flu will do next year, or what increasing flu vaccination in a particular group will result in changing next year. But we can, through the methods that we showed you, have a framework for taking into account all of the uncertainty and making an informed decision about which intervention is, or what is going to be the most likely outcome next year. So it might not, it might be difficult to forecast and make accurate predictions in that sense, but that doesn't necessarily, that nevertheless means that they are still in some ways even more valuable, because they are a tool to handle that uncertainty in making decisions about the future, where you have a set of alternatives that you have to choose from. I don't know if that answers your question. But,
Yeah, I think that was excellent, really detailed. Thank you so much. We have reached the end of the hour, so I do want to say thank you all for your fantastic presentations today, and a big thanks to the audience for participating. So thank you again for being here, everyone. And a big thanks also to the sponsor, ICON. In closing, we hope you enjoyed this webinar, and we'll see you again next time.